Mr. X, 53 years old male, presented with complaints of dyspepsia for 8 months, difficulty in swallowing for 3 months, loss of appetite and weight loss for 6 months. According to patient statement, his presenting complaints started 8 months back with back epigastric pain, which was initially episodic, later continuous, dull aching in nature, no radiation, aggravated by taking food associated with early satiety, and which is gradually increasing in intensity, for which he regularly took proton pump inhibitor but not treated. For last 3 months, he experienced progressive difficulty in swallowing solid foods, described as episodes of food sticking in his chest and sometimes regurgitating back into his mouth. He could tolerate semi-solid food. He had history of loss of appetite and about 12 kg unintentional weight loss in last 6 months. He had no history of fever, vomiting. He gave no history of cough, hemoptysis, hematemesis, jaundice, chest pain, or bone pain. His bowel and bladder habit are normal. He recently consulted a physician and he prescribed him helicon kit, amoxicillin, clarithromycin, and lansoprazole combination. He completed the dose but not improved. Normotensive and has no other comorbidities. He has no history of taking non-steroidal anti-inflammatory drug, no history of blood transfusion. None of his family members is suffering from this type of illness. He is immunized, received 3 doses of COVID-19 vaccine. He is non-alcoholic, non-smoker, occasional veterinary chewer. On examination, he is anemic, not icteric, BMI 20.1, ECOG performance status 1. All accessible peripheral lymph node, including the left supraclavicular, are not palpable. Pulse 66 beats per minute. Blood pressure 110 by 70 millimeter mercury, temperature 98 degree Fahrenheit, respiratory rate 15 breaths per minute. On examination, abdominal examination, abdomen is scaphoid in shape, flank are not full, umbilicus centrally placed, inverted vertical slit, no visible peristalsis or scar mark, hernial orifices are intact. No tenderness is noted on superficial or deep palpation. No palpable lump. Liver and spleen are not palpable. Kidneys are non-velatable. Upper border of liver dullness is in right fifth intercostal space in mid-clavicular line. Percussion node is tympanitic. Shifting dullness is absent. Bowel sound is present. Rectal examination and other systemic examination revealed no abnormality. So my clinical diagnosis is carcinoma of proximal stomach involving gastroesophageal junction.
Thank you, Dr. Abdullah, for presenting your case. Now we'll face your examiner. Mr. Magum, sir, will you make any comment about his history presentations?
A typical history that we usually expect.
Right, sir.
মোটামুটি আর কি খুব ইয়ে না
ওকে স্যার ইয়া ঠিক আছে আর ফ্যাকাল্টিতে কমেন্ট নেই and Professor Ibrahim, will you ask any comment question to Dr. Abdullah?
Thank you very much for the presentation. Okay, why it is not a case of carcinoma of the lower end of the esophagus? Because the complaint was dysphagia, isn't it?
Yes.
Sticking at the lower end of the chest. So why don't you go for carcinoma of the lower end of the esophagus?
Because his disease progression starts with dyspepsia followed by dysphagia. That's why I consider it proximal gastric cancer involving GE junction, later involving GE junction.
Do you think that the dyspepsia only is the feature of carcinoma of the stomach?
No.
In that case, can you change your diagnosis? Clinical diagnosis, not of the investigations. You have said that for the last 3 months, you experienced progressive difficulty in swallowing solid foods. Describes episodes of food sticking in his chest. that is a classical feature of carcinoma of the esophagus, isn't that?
Yes, sir.
There's only dyspepsia can outrule the diagnosis of carcinoma of the esophagus.
Sir, carcinoma lower end of esophagus also a differential diagnosis of my case.
Okay, let us proceed. Thank you.
Okay. Professor Mojid, sir, will you make any comment or will ask any question to Dr.
Yes, I just want to know why did he want to elicit shifting learners? What is the basis for trying to elicit shifting dullness in this particular patient?
Shifting dullness is important to see ascites. In case of ascites, it may be due to metastatic disease, peritoneal
Yes.
metastatic.
But the question is, do you suspect shifting dullness in a patient who has got a scaphoid abdomen? Abdomen is scaphoid, you said, did you not? Or it looks scaphoid?
Not in this picture.
in this case?
Another one picture in the initial picture.
So it will
Maybe
be
this is the maybe this is the latest picture on the diagnosis. And the abdomen was scaphoid in shape.
It looks anyway. If there is no suspicion of, you suspected that there could be ascites, is that right? And what was the basis for your suspicion?
No basis. I actually done it as a part of abdominal examination.
Oh, I see. I think for a postgraduate examinee, you must justify unless there is a possibility of, because it doesn't look that there's fluid in the, and I want to, one more thing I want to know from you. What did you expect to find on digital rectal examination? You said that it was normal.
In case of in this case, there may
You
be,
said that that is normal. Is that right?
yes, sir.
And what did you expect to find in a patient with gastric cancer?
On rectal examination, on digital rectal examination, there is presence of Balmer shelf in case of metastasis, and that is palpated on digital rectal examination.
Only rectal shelf of Balmer, or do you have something else also? You can also palpate the peritoneal seedlings.
Yes, sir. Also peritoneal seedlings.
Yeah. Okay. Thank you.
Thank you.
Sir.
Thank you. Dr. Shivendra, now my your hand. Please ask questions.
Abdullah, you also made a diagnosis of CA proximal stomach. Why so specific on history and clinical examination that it is a proximal stomach tumor? How you came to make a diagnosis?
Okay, now most of the stomach cancer is now around the G junction, proximal, around 60% prevalence. And in this case, he has
your incidence in Bangladesh, the proximal stomach is more common?
not common, but prevalence increasing is amount.
But you said 60% of cases of CA stomach are proximal. But that is not in our center. I don't think whether what is in Bangladesh, but still we have more for distal malignancies. Proximal is increasing, but it still is not more than the distal tumors.
Okay, he has no feature of distal carcinoma stomach like vomiting, epigastric fullness. That's it.
Second thing, you have not given any taken history of any melena. Your hematemesis you mentioned, but
Yes, I
melena,
have mentioned.
you should mention. And also, you have not mentioned any past history of symptoms or history of reflux disease. Because these tumors are usually, proximal tumors are associated with reflux and long-standing reflux leading on to malignancies, and that could be one reason for it. But nowhere you mentioned any reflex problem symptoms, only dyspepsia for 8 months. So difficult to have explained dyspepsia leading to malignancy in 8 months. The predominant symptoms based on this appears to be difficulty in swallowing. So it could be still be the lower end esophagus, and rather than just pointing that it could be only CA proximal stomach. The
Yes, sir.
predominant symptoms is dysphagia.
Yes, sir.
Okay. So you can proceed. Mr. Shivendra, you can proceed about these about investigations, I think, and subsequent plan.
So Abdullah, how you will proceed? Now you have made a diagnosis. That is a CA proximal stomach.
For diagnosis purpose, I will do a upper GI endoscopy and biopsy from suspected lesions.
And no other investigations.
Then after that, I want to see the investigations of upper GI.
What are the findings on upper GI?
Microscopic examination, upper GI endoscopy findings, carcinoma stomach with involvement of lower end of esophagus. So I want to take 6 to 8 biopsy from the growth and send for histopathology.
And what is the extent of growth? It is mentioned on the.
Not mentioned. Only involvement of lower end of esophagus is described.
So that is a very important one. Of the lesion.
Yes, this is the very important for classification of G junction tumor by Schwartz classification and subsequently prognosis of the disease and management of disease.
What else you wanted? Because it mentioned that the mucosa of cardia and fundus is involved and thickened and nodular, but no other mention whether it is on the lesser curvature side, what is the extent of the disease on the stomach.
So this is not a complete report.
Okay. So how you will proceed now? It is there is a growth in the stomach with involvement extension into the lower esophagus also.
So our histopathology report, microscopic examination section showed a malignant composed of malignant epithelial cells having mild pleomorphism and large hyperchromatic nuclei arranged mostly in diffuse pattern invading underlying stroma, impression tissue from body of stomach, biopsy, adenocarcinoma. This report is also incomplete. They haven't mentioned grading of adenocarcinoma.
How that will change the management?
Not change the management, but it is a prognostic factors. Poorly differentiated carcinoma is a bad prognostic factor. And they haven't mentioned the diffuse variety or intestinal variety in the impression. This is also a prognostic factors.
Okay. So how will you proceed now after this endoscopy and biopsy?
So I want to stage the disease by CT scan of chest, abdomen, and pelvis. In case of CT scan of abdomen, I will do IV contrast and oral contrast both.
Why you want to give oral contrast, positive contrast?
I want to see the extent of disease in the stomach. That's why I want to give oral contrast.
Why can't only plain water will do? You only want to distend the stomach. Why you want to give positive contrast?
Oral contrast can delineate lesion more clearly rather than a negative contrast.
Is it?
I think there is no need for giving more of positive oral contrast because you not like to see the mucosal irregularities on these. Only purpose is for distancing the stomach, you need to give oral contrast, and that plain water will be also sufficient. It will be much better. And will you not like to do an ultrasound first or directly CT scan chest and abdomen? What is your practice, your place?
We are now practicing directly contrast enhanced CT scan of abdomen, CT, chest, pelvis. Ultrasonography is not routinely recommended in NCCN guideline.
Dr. Shivendra asking you, what is your practice in your institute? Do an ultrasonogram or a CCT? What is the routine practice?
Because being at our tertiary care center, we do CT scan, but in our place also, most of the smaller places, we usually do ultrasound because of cost constraints. If on ultrasound we find the liver mets are there or some free fluid is there, then you don't need not to waste money on the CT scan and chest. That is the usual protocol in the primary care centers or secondary centers.
Okay.
So what is the finding of CT scan? And what all you wanted to see on CT scan? May name what you want to see.
I want to see the lesion, exactly site of the lesion and extent of the lesion in the stomach and in the D junction, and extent of the length in the D junction for source classification. And I want to also see there is lymph node involvement, and is there any metastasis in the liver or in the peritoneal metastasis or pelvic deposits. And in case of CD chest, I want to see any metastasis in the lung. Also in the abdomen, I want to see the major vessels. Is the vessel is involved or encasement present, and the plane between the stomach and surrounding pancreas, and is there any fat plane is intact between stomach and pancreas, and that's it, sir.
Okay. What is there in this CT scan?
This is a contrast, IV contrast enhanced CT scan of abdomen, axial view in the left side. There is a thickening of the gastric wall at fundus and involving the gastroesophageal junction on the left side. This is on the right side. This is coronal view. I want to see again, please, coronal view. Yes, this is also, there is also gastric wall thickening in the proximally, like a fundus and laser curvature and gastroesophageal junction, and there is no liver metastasis or peritoneal deposits. All of the celiac trunk vessels are not encased, and I haven't seen any lymph node there.
And what is the proximal extent of the disease?
Sir, coronal view again, please. Scroll. Scroll, please. I think this is bound to abdominal esophagus. This is Schwartz type 3.
It is not crossing the diaphragm,
Not crossing the diaphragm.
and the lower esophagus, how much length is involved?
I haven't clearly tell the length. Approximately around.
You will get abdominal esophagus somewhere is normal.
Sorry, sir.
Is the abdominal esophagus in any part is normal, so that you have some margin later on if you plan?
Yes, sir.
I really doubt on this scans whether we'll get a normal abdominal esophagus. Also,
Yes,
what
sir.
is the extent of the stomach involvement?
Stomach involvement, just seeing the fundus and a part of adjacent laser curvature. Not body is not involved.
But it appears in this scan, you can see that it is extending along the body also,
Yes.
proximal body.
Yes, sir. This coronal section. Yes, sir.
It appears the proximal body is also involved.
All involved, sir.
In this cut, you can see just whether you will get some margin. Yes. Upper margin also might be difficult. Okay, now it is, so what stage it is now?
Quite advanced.
So what will be your further plan now? It is locally advanced disease.
It was before AN1MG.
Sir, I also want to see the CT scan of chest report.
Chest is empty.
Okay, sir. Then
I don't know the feeling, but the suggestion of the carcinoma of the lower esophagus, the extension through the cardioesophageal junction in the fundus of the stomach.
Any tumor marker done for this case, carcinomembranous antigen CA19-9 or 72-4.
What is the role of this tumor markers? How it will your change management?
No, it will just about burden and prognostic factors, and it will help us later for follow up the patient.
Are there any tumor markers which are specific for CS stomach and which are routinely recommended?
No, sir.
So why you want to do tumor markers? What else should be done for these locally advanced tumors?
So I want to see immunohistochemistry from tissue and MSI or MMR, and later I want to do a PET-CT scan. According to NCCN guideline, as is there no evident M1 disease, so I want to do a PET-CT scan to see any occult metastasis.
I think a PET should be done, but if it is not available, CT scan, chest and abdomen is okay. If it is otherwise, recommendation is to do a PET scan.
Yes, sir.
And now there is no meds. You have done a staging. What else you will do?
So I want to also see the immunohistochemistry report of genetic analysis like MSI or MMR, HER2 and PDL1 in case of locally advanced malignant stomach cancer.
Okay. So how it will change? Again, the change.
In case of deficient
Do you do in
MR,
your place, you do MSI HER2 for all patients?
no, not for all the patient, for locally advanced case or metastatic case, but all newly diagnosed carcinoma stomach case, now MSI or MMI is recommended in the NCCN guideline.
I think we have to follow NCCN, but we have to see the local logistics cost and all. Whether MSI, how many patients will get HER2 positivity will seen in around 10%. You'll waste money for that patient for 90% of patients.
Yes, sir.
If it is available easily, recommendation is to do.
Yes, sir.
Okay.
So now at this stage, I want to arrange an MDT for my next proceed.
So what is your treatment plan for MDT? What you are planning?
My planning is a staging laparoscopy and then proceed.
Okay. So did staging laparoscopy was done?
Staging laparoscopy reports, sir.
Staging laparoscopy in this patient didn't have any staging laparoscopy. Didn't have any staging laparoscopy.
But in this case, stage T4A, this is serosal involvement, and there may be micrometastasis in the peritoneum. So in this case, staging laparoscopy and peritoneal level cytology is a must for this case. NCCN recommended for clinical T1B or higher cases, every case staging laparoscopy is a must with a peritoneal level cytology. So this is help us for further management. Cause in case of staging laparoscopy in recent some studies, around 31% cases there is peritoneal or organ metastasis, and in case of peritoneal level cytology, this is M1. If peritoneal level cytology is positive, then this is M1 disease, and the whole treatment plan is changed to palliative therapy or other therapy. So this is a must for this case.
Yeah, I totally agree. It should be done, but again, the problem remains in our setup and sometimes logistics and all. If you are not, then your plant go ahead with neoadjuvant chemotherapy.
Yes.
If possible, try to do laparoscopy whenever it's possible.
Okay. Then.
So
Yes.
I want to.
Sorry.
So I want to select neoadjuvant chemotherapy. So there is two things. One thing is neoadjuvant chemoradiation or neoadjuvant chemotherapy. This is my question here from the oncologist, because in recent trial, FLOT trial, ECF trial, another trial, FLOT trial is perioperative FLOT therapy is increasing the disease-free survival and overall survival around 50 months. And in case of SWAS type 2 or type 3 cancers, now in the cross trial, neoadjuvant chemoradiation, overall survival, median survival is around 49.5 months. So around near about same. In case of G junction tumor for locoregional control, according to cross trial, chemoradiation is a good option, but perioperative FLOT is also superior to any other regimens in case of proximal gastric cancer or gastric cancer. So this is my question to oncologist: whether we select perioperative FLOT therapy or preoperative chemoradiation in this case, as this is a SWARS type thing.
Okay. What is your opinion, Shivendra?
I think, Abdullah, first you have to decide what is your surgical plan future. In this whole almost proximal body is involved. What you are going to achieve and what you are planning to do later on. Usually for radiation for such extensive gastric involvement is not a good idea. And the cross trial also in some subgroup analysis showed trend towards slightly better recurrence-free survival, especially in node-positive disease. But now with the new evidence of prospect trial, so there is no added benefit of doing radiation. Float or perioperative chemotherapy is best, wherein lesser morbid as compared to chemoradiation. So I'll prefer at present evidence to give perioperative chemotherapy is better. If he can tolerate float, that is the best option he should have.
Yes. Thank you. Float is the best option for this patient. So patient had this float regime, and after having this float regime, patient had this. How will assess the patient, Dr. Abdullah?
Now I again want to do staging by CT chest, abdomen, and pelvis, and after that I will proceed with again staging laparoscopy again.
Okay, this is the post float CT scan. Okay.
Okay, this time comparing with the pre-NSCT CT scan, now the wall thickening is decreased and abdominal esophagus is not involved. I think the disease is down-staged now.
So what will be your plan?
Okay, then now I will do a staging laparoscopy to rule out any peritoneal metastasis or any.
And what is your surgical plan?
Now my surgical plan is I want to do total gastrectomy with D2 lymphadenectomy and with the help of frozen section for proximal clearance margin with Roux-en-Y esophagojejunostomy.
Okay.
So this is the report, CT scan T2N0M0. And this is the endoscopic comparison between the pre-NSCT and the post-NSCT.
Yes, sir.
Okay. This is your, again, at this time, this staging laparoscopy. No evidence of the any mets or any deposits or anything.
Yes, sir. In the third picture, there is some changes in the intestine, most probably a side effect of float therapy. The toxic side effect of float therapy.
What do you think, Dr. Shivendra?
I think some fluid might have been there or some serosal deposits might have been there. But then no obvious mets are seen.
No obvious mets are seen, right, exactly. Okay then. So about plan of surgery, do you agree, Dr. Shivendra, what Abdullah said?
When the CT scan, they were showing the coronals. I think I was doubtful that we'll get a good esophageal margin. That was, I'm a little apprehensive. This hold on, go on slow. And the G junction, it appears slightly thickening, reaching up till hiatus. It was involving lower part of esophagus also.
Okay.
That way, but on this contrast, it appears that we might be able to get oral contrast with this. It appears that we might be able to get this. Yeah, just hold. I think
yes, sir, I want to do in the abdominal approach and transhiatal approach.
Transhiatal, what you are planning to do?
Lymphadenectomy, lower mediastinal lymphadenectomy also needed.
I think a lower mediastinal lymph node should be done. But if it is type 3, then not much. You have to just station 110, you have to clear. But if it is extending beyond, then you have to give complete lower mediastinal lymph nodes. So what will be your plan? Because the stomach was also involved till proximal body. In case intraoperatively, how you will proceed?
I will do for total gastrectomy and proximal margin with frozen section. Proximal margin clears by frozen section and
Divided the duodenum, and later on frozen came negative positive. So what you will be stuck up, then what will be your plan?
esophageostomy.
But if it is going higher up, how you will be sure that you will get higher up and you will be able to reach?
So in these cases, thoracic approach must be needed.
First step should be, after doing laparoscopy and laparotomy, you have to assess the lower esophagus first. So you have to dissect the hiatus, see how the esophagus is, whether you will be able to get the margin from abdominal approach or not. If you are
Yes,
not
sir.
able to get, doubtful, then send a frozen section, but don't divide. And
Yes, sir.
pylorus, don't do any irreversible approach till the time you are sure that you will be able to get a margin through abdominal approach.
Yes, sir.
Because if you need to do thoracic approach, then the stomach should be also normal and should be able to reach, and the gastric margin also should be good.
Yes, sir.
Okay, fine. Those are very, very important steps and tips of the surgical procedure during surgery. And yeah, so actually, what happened? The surgeons who has sent this patient to us in the first frozen section, a margin was involved by the tumor, and subsequently. The second section was sent, and that was free from the invasion, and he did it through the abdominal route. And ultimately, what he performed, a total gastrectomy with this esophageal UNY, along with the D2 lymphadenectomy. Will you make comment?
I think if he is able to get a frozen section negative, then it's okay.
Yeah,
Because for esophagus margin for type 3 G junction, I think the frozen negative margin is okay. But it is, at least we should try to get 2 centimeter margin. But even if frozen is negative and lesser than 2 centimeter, then also it's okay.
Okay then. And finally, the histopathology report came as
Pathological staging YPT3, YPN0, YPMX, and total lymph node harvested there only 4 lymph node from the level 2.
Are you happy with the lymph nodal dissection?
No, I am not happy with this lymph nodal dissection. But one thing is this: in case of chemotherapy, most probably lymph nodes are normal. This case
reduced in number.
Usually it might come down, but still at least 15 nodes should be there at least.
At least
this is sub-centimeter lymph node. That's why probably pathologist haven't dissected. I want to review the report for more lymph node.
And also, again, the issue is it is poorly differentiated diffuse type.
Yes, sir. This is both are the bad prognostic factor.
And spleen is also involved. So splenectomy needed to be done.
Yes, sir.
Okay. So how we proceed now?
what next?
So I will, as already a 4-cycle float is given preoperatively, so I will give later on 4-cycle adjuvant therapy adjuvant chemotherapy, and discusses with on MDT, re-MDT.
Dr. Kamal, are you here? Kamal. No, probably not. Okay then. What is your opinion, Dr. Shivendra, now?
We need to complete the 4 cycles slot,
Right.
but we need to prognosticate because it's diffuse type, poorly differentiated, spleen is involved. And that also, again, the spleen is involved, and why it is YPT3 only.
Yes, sir. This is my question, sir. Why PT3? Sir, I have a question in this state. Is there any rule of prophylactic HIPEC in this case if this is available in resource countries?
All this, there is a huge data for prophylactic HIPEC, especially for locally advanced T3, T4 tumors. These patients should be offered HIPEC if the facility is available. So now it is now recommended for, and prophylactic HIPEC is now even the NCCN recommends for locally advanced tumors.
Yes, sir. As their PCI score is low, PCI score is 0, so this will improve.
If it is a prophylactic HIPEC, the chances of local recurrence decreases. That is the benefit of giving the.
Yes, sir.
Okay then. Okay, thank you very much. I think we discussed a lot on these cases. And now, any question from the students? Any question from students?
Sir, Stewart type class 1 to 3, treatment of Stewart class type 1 to 3.
I think that will be clear from Dr. Shivendra Singh's presentations. Okay. Or Shivendra, will you tell about?
I'll cover in that.
Yes, you will cover. Okay then. Any more question? Or any comment from any faculty member? Okay, now the time is yours, Dr. Shivendra. You please present your case. My presentation. Give your presentation. Okay. I have posted you. Yes, I posted. You please share your screen.
Let me just share. Are you able to see?
Yes.
Cancer this time. Last time covered gastric cancer, mostly on the natural gastric cancers. So few things I'll be not covering in detail in this time. So as you know, the cancer in stomach is the leading cause of cancer after lung carcinoma, leading to death. And incidence has been decreasing in the West due to changes in diet, food preparation, and environmental factors. But incidence of proximal gastric cancer has been on the rise.
Recording in progress.
This, if you are able to see, this is the part of fundus, and this is the G junction area. And this includes the proximal, but also a proximal body is also included in the proximal gastric cancer. Not only the fundus or G junction, even the proximal body treatment remains almost the same. So what is the G junction? For surgeons, it should be depend on the angle of his. This is the part where we'll suspect a G junction. For endoscopic, it is the proximal extent of the longitudinal gastric folds, and same will remain for pathologist. And there is no reliable radiographic definition of G junction, though it is best seen on coronal reconstruction of CT scan, where you can find the G junction to locate it. But the location of G junction might be affected by factors like diaphragmatic movement, presence of Barrett's esophagus, and hiatus hernia. And these hiatus hernias and Barrett's are very common in proximal gastric cancer because these are usually associated with long-term reflux disease and later on leading to malignancy. So you can see this is the squamocolumnar junction, this is the angle of it, and this is the G junction. And the G junction is originally traditionally divided proximal to G junction is to be treated like esophageal malignancies, and distal to G junction should be treated like gastric cancer. This was the traditional concept. But the Cancer Genome Atlas Research Network, when they analyzed the genomic profile, the whole of the G junction tumor behaved like a common gastric organ, not like the esophageal malignancy on the genomic profiling. But for management of point of view, or surgical management point of view, the G junction is classified into 3 types. The Sieverts is the most common classification used in the West, and Nishi classification is mostly used in the Japanese centers. Usually any tumors located with the bulk of the tumor within the 5 centimeter from G junction, these are classified as G junction tumors. And you have to note the 1 centimeter toward the esophagus and 2 centimeter toward the gastric. These are type 2 G junction. Proximal to that is type 1, and distal to this is type 3 G junction. For Nishi, it remains within 2 centimeter of G junction, it is G junction. But for most of the practical purpose, we use Sievert classification based on the location of tumor from G junction. So 1 centimeter toward the esophagus or 2 centimeter toward the stomach, that is type 2 G junction. And above this is type 1 and below is type 3 G junction. So coming to the management, evaluation and diagnosis, I think it is covered. Presentation is usually most common is weight loss, abdominal pain are most the common symptoms. For proximal, G junction tumors present mostly with dysphagia or rarely with the GI bleeds. So always these are the findings that we must always shoot for the Blumer shelf, Ruckenberg tumors, left supraclavicular lymph node, umbilical nodule. These should be examined during the routine abdominal examination. Upper GI endoscopy remains the best method to diagnose gastric cancer, and with the availability of NBI, narrow band imaging, it should be done if you are not able to identify any lesion or any suspicious micro irregularity is seen. The NBI helps in finding the suspicious area. Like this in patient, you can see this is there a slight irregularity is there. When you do a chromoendoscopy by indigo carmine, you can find this is the area which is suspicious and you should take a biopsy. Similarly, for narrow band imaging also will help in locating these type of tumors. If for EUS is always required, especially if you are suspecting early gastric cancer and you are planning a local therapy, or otherwise also for all staging purposes, it is recommended. But in our setup, only if you are suspecting very early gastric cancer, T1 or T2, then the role of EUS comes out. Or sometimes if there is a diffuse type of malignancy or sometimes a biopsy comes out, and so you have to take a deeper biopsies or EUS guided biopsy deeper so that to get the biopsy conclusive proof. So if you see, this is how the EUS looks like. All the black area that you see endoscopic ultrasound is the muscle. Above the superficial is the mucosa, then comes the muscularis mucosa, then the submucosa, and then muscularis propria, and then the serosa. Same way, if you see in the endoscopic ultrasound from inside to out, it is mucosa, this is bright, then this black layer is muscular is lamina propria, then the muscularis propria, and submucosa. So CT scan in our setup, most of the time we see is advanced cases. The CT scan remains the best investigation to modality to see the extent of disease, to assess the resectability, and plan the surgical management plan. But it is not good for detecting peritoneal metastasis, especially in these patients. A PET scan role comes, which might be able to see a smaller peritoneal mets better as compared to the CT scan. Also, the role of laparoscopy comes. because the CT scan is not good investigation to evaluate the peritoneal disease. So FDG PET is recommended at present to rule out any evidence of metastasis in CS stomach patients. But if you are getting a patient with linitis or signet ring cell carcinoma or a mucinous tumor, then the FAPI PET is the better to do, because the FDG PET is not shows avidity in these tumors of signet ring cell. So if it is signet ring histology, there is no role of doing FDG PET. Better is to do a FAPI PET. And it is again not a replacement for staging laparoscopy, because the sensitivity of PET is only 50%. So it does not have a good negative predictive value, but it has a good positive predictive value. There is no role of any tumor markers for CS stomach. Biomarkers, if you're planning and your patient can afford, the heart tube, MMR testing, PDL testing should be done to plan neoadjuvant treatment, because in FLOT, in addition to that, you can do a heart tube testing and targeted drugs can be added, or even an immunotherapy given in a neoadjuvant setting. So coming to the staging, once you do a staging, then this is the staging that you can find for T1 lesion, which is confined to lamina or still submucosa. These are T1 tumors. Most of the other tumors that is beyond submucosa, whether it is involved in muscularis propria, these all patients will need a neoadjuvant treatment. The nodal disease is based on the number of nodes, but still you have to see the location of the nodes on CT scan. If it is paraortic nodes are seen and huge retropancreatic nodes, these are usually contraindication for local resection, because these are taken as metastatic disease. And this is the stage grouping. So always once you find that staging laparoscopy should be done to rule out occult metastasis, because in around T4 patients, up to 50% patients on laparoscopy. If no peritoneal disease is seen, one should do a peritoneal cytology, and if it is positive, it should be taken as a peritoneal disease. So all positive peritoneal cytology patients behave like patients with peritoneal mets and should be treated as a stage 4 disease. So coming to the management of CS stomach, I will focus more on the proximal stomach patients. So its local role of stage 1A, that is up to submucosa, the role of endoscopic resection also comes up, because in these patients, even EMR should be sufficient, but these patients are very rare in our setup. In a year, we see only 1 or 2 cases in which endoscopic resection can be offered. But in these patients, also always look, if it is early lesion, then do endoscopic ultrasound. And if it is real T1 and node negative, then one can consider endoscopic resection. And always one should look for the low risk, whether it is well differentiated, less than 3 centimeters, no LV, then only plan for E. Rest of the all patients follow phase 2 to 3 patients, and these patients usually need perioperative chemotherapy or chemoradiation. Now with the newer data, perioperative chemo is better as compared to the chemoradiation. So coming to the, I will not go into detail. The FLOT is the standard. In last lecture we have covered. The FLOT is the best chemotherapy for a neoadjuvant treatment for CS stomach. The FLOT remains the best modality at present. Coming to CF surgery for proximal CS stomach, this is the algorithm for all gastric cancer. If you can see, it is T1B and it is well differentiated, then a D1 gastrectomy is sufficient. But if it is not well differentiated, then it is better to do a gastrectomy, but D1 plus. So D1 plus or D2. We prefer doing a D2 if it is T1B and submucosa is involved, because later on we should not have after surgery that it comes out the way on final pathology it is poorly differentiated and we have done only D1 gastrectomy. If it is node positive, even for T1 disease, a D2 gastrectomy should be done. Rest all T2, T3 tumors should undergo a D2 gastrectomy. These are the perigastric nodes or level 1 nodes. This is level 1 is right pericardiac. Station 2 is left cardiac. Station 3 is along the lesser curvature. Station 4 are around the greater curvature. 5 is suprapyloric and 6 is infrapyloric. Similarly, for level 2 stations are along the left gastric, common hepatic artery is 8A, celiac is 9, splenic hilum is 10. This splenic hilum node is important for proximal gastric cancer because they can directly spread to station 10 lymph node. All these splenic hilum lymph nodes should be cleared for proximal gastric cancers. 11P is the proximal splenic, 11D is distal, and these also should be cleared in proximal gastric cancers. And 12P and 12B are usually not required for proximal gastric cancer, but 12A, if it is extended toward the body, then 12A should be cleared. Similarly, for type 3, type 1, type 2 G junction, this station 110 or the paraesophageal lymph node should be cleared. And if it is type 1 or type 2, but it is going more than 2 centimeter into the abdominal esophagus, then the supradiaphragmatic station 111 or 112 should be cleared. And these will require a thoracic approach to have a better clearance. So for level 110, 111, 111 and 112 should be taken out in type 1 G junction or type 2 with extension into the esophagus more than 2 centimeter. So usually the resection margin we should try to get at least 3 centimeter for stomach margin, for 5 centimeter for stomach for infiltrative growth pattern, but for the proximal tumors, the esophageal margin should be 2 centimeter. Try to get 2 centimeter esophageal margin, but even a negative frozen section is sufficient to avoid the morbidity of thoracotomy. So nodal dissection, as you know, the minimum of 16 nodes should be done there for proper AJCC staging, and removal of more than 30 lymph nodes are desirable. This also I have discussed in the last lecture also. So D2 gastrectomy is D1 plus lymph nodes along the branches of celiac, that is station 7 to 11. D3 gastrectomy and D4 are usually not recommended at present because of higher morbidity and no benefit in overall survival. For proximal gastrectomy and for D2 gastrectomy includes station 110 should be included, and for D2 for total gastrectomy station 10, 11D should be included, and if it is extending beyond the 12A should also be resected. So this is the extent of lymph nodal dissection for total gastrectomy for proximal gastric cancer. So role of D3 lymph node dissection is controversial and it is not recommended at present, especially and rarely if a left paraortic node is there and that is the only M1 site. After chemotherapy, one can offer a D3 lymph node dissection, but still it is not a standard of care. So this is the data which has shown that there is no benefit of D3 and no additional survival advantage over a D2. And this is a Japanese study. Similarly, another study for D2 plus D2 and paraortic nodal dissection for advanced gastric cancer. Again, there is no improvement in overall survival. So at present, D3 lymph node dissection or paraortic nodal dissection is not a standard of care. Coming to the management of G junction tumor, which is controversial. As you can see, it has changed in various last 2 AJCC. We are still awaiting AJCC 9th edition, but AJCC 7th edition, all G junction was treated as a C esophagus. But in AJCC 8th, several type 1 and 2 tumors were kept for esophageal malignancy to be staged, and stage 3 tumors or type 3 SIVAT was to be staged as gastric adenocarcinoma. So at present, this remains the true because the 8th edition is still following, and same is recommendation from NCCN guidelines. So type 1 and 2 tumors should be staged like esophageal malignancies, and type 3 should be staged like gastric malignancy. So coming to management, again remains the type 1 is easier to manage esophageal malignancy. That is why you need to do a total esophagectomy, do a macular esophagectomy or a transarterial esophagectomy, and do a gastric pull-up. For stage 3 also it is clear. It is do a total gastrectomy, that will be standard and that is easier. Controversy remains for type 2 and whether to treat like esophagus or do a gastrectomy with distal esophagectomy, and that remains for type 2 severe class has a controversial treatment. Again, coming to the early stage, you can do a endoscopic resection for these tumors, but very rarely you will get a EMR or ESD for type 1, type 2 G junction unless you get a very real type 1A tumors. All these patients for G junction should remove neoadjuvant therapy. Usually there was controversy whether a FLOT or cross trial, but with now the SOPEC trial, which has shown the overall survival is better with FLOT and the morbidity of chemoradiation was higher. So now the recommendation is to FLOT because it has same overall survival with lesser morbidity. And so the FLOT is the standard of care at present. And the SOPEC trial came in 2024 only. Coming to surgical management, it is challenging for G junction tumor remains. For type 1, you need to do esophagectomy with 2-field lymph nodal resection. 2-field lymph node resection means you have to clear the abdominal lymph nodal clearance and the lower mediastinal lymph node clearance till the carinal level. You don't have to do a supracarinal lymph nodal dissection, and that is the 2-field lymph node dissection. So that you can achieve by doing a MACUS or IVL esophagectomy. For type 3, a total gastrectomy with extended lymph nodal dissection, including extended to 111 should be included in all patients, and 111 and 112 should be included in if it is extending along the esophagus more than 2 centimeters. For severe type 2, I'll come. So what is the benefit, pros and cons of these two approaches? For type 2, if the esophageal extension is more than 2 centimeters, then it is better to do esophagectomy if you can get a good gastric conduit. So more than 2 centimeter extension, better is to do esophagectomy because you will not be able to get esophageal margin from abdominal part. So that is why in these patients, esophagectomy, preferably IVL should be preferred. And it has been getting a better mediastinal lymph nodal clearance. Different problem remains, the thoracic dissection is required and the intrathoracic anastomosis is there, which has a slightly higher morbidity and complications. If it is less than 2 centimeter extension in type 2, then you can offer a total gastrectomy. But again, there remains if it is diffuse gastric involvement or nodal extension, then you might need to do a nodal clearance and do a thoracic approach. But most of the time, if it is less than 2 centimeter esophagus involvement, you will be able to get a esophageal margin negative as well as adequate transarterial lymph nodal clearance from below abdominal approach. So total gastrectomy should be sufficient if the esophageal involvement is less than 2 centimeter. Proximal gastrectomy also some groups have started doing, but it should be offered in early stage of disease like T1 or T2, type 2 G junction, and less than 2 centimeter involvement. Otherwise, for bulky T3 and T4, proximal gastrectomy is not a good choice. So IVL remains for in difficult type 2. If it is extending more than 2 centimeters, IVL approach is better through upper abdominal and the right thoracoabdominal approach, and this gives a better lymph nodal clearance with anastomosis in the chest. Other approach, what many centers in UK used to follow is left thoracoabdominal approach, but it increases the morbidity of thoracotomy because you have to cut the rib cage, and this is much more painful. And also, with this approach from left side, sometimes it is difficult to get adequate lymph nodal clearance of station 1, 2. So that is better to have a IVL approach with 2 separate incisions. And that is why this study has shown that left thoracoabdominal approach does not improve survival and as compared. So that is why the left thoracoabdominal approach is not good for these patients. If in type 1G junction, macular esophagectomy is better, that is gets a three-field lymph nodal clearance, abdominal and chest. And if there are some nodal clearance in the neck, then also it be cleared. But for adenocarcinomas, usually three-field lymph node dissection is not required. Two full lymph node dissection with the anastomosis in the neck is sufficient. So similarly, now with the advent of laparoscopy, robotic and thoracoscopy, definitely all these approaches can be done by minimal invasive approach, and the time trial has shown the minimal invasive approach is better as compared to open esophagectomy. So this is what we have published in our experience in 2 years back. Now we have done more than 200 now robotic esophagectomies, and this has a better post-operative outcome, lesser morbidity, lesser chest complications. So coming to the proximal gastrectomy, how to do the reconstruction. If you are planning a proximal gastrectomy in type 2G junction and early disease, either T1 or T2, node negative, then you can do a proximal gastrectomy. Then you can do a reconstruction by esophagogastric anastomosis, but problem remains of high reflex and which has a high morbidity. Second approach is doing a jejunal interposition between the esophagus and the gastric remaining stomach. But this approach has a problem in emptying from the jejunal graft because of less of peristalsis in this segment. Then came the double tract reconstruction. In this, you do a Roux-en-Y reconstruction, but side to side anastomosis with this stomach. This helps in continuity from this entropolaric route so that the nutritional problems are lesser. And also there is no emptying issue because it is directly connected down. So there is no effect on the emptying also. So the double tract reconstruction is also a good option, but it increases the another anastomosis and its complications. So for adenocarcinoma, I think you need to do station 1 and 2, lesser curvature, and these are the most important nodes to be involved. You can see that station 1 and station 2 are involved in almost 30% of patients. In lesser curvature, nodes are involved in around 40% of patients. So all these nodes should be cleared. If you see, the celiac and proximal splenic nodes has a positivity rate of 10%, and the proximal station 10 nodes or station 11D should also be cleared, especially for proximal type 3G junction. And for the nodal station most likely to involved in G junction includes less than 2 cm esophagus should be adequately cleared by proximal gastrectomy. If you compare proximal gastrectomy versus total gastrectomy, those at present the Japanese guidelines also recommend it for only early stage T1 tumors proximal gastrectomy. For more than T1 or node positive, better is to do a total gastrectomy. So for CVL2 tumors, the clinical practice has been variable, but total gastrectomy can be done with a reasonable margin if it is esophageal involvement is less than 2 cm. If it is more than 2 cm, better to do a esophagectomy. And there is cardiac trial is ongoing, which is comparing transthoracic esophagectomy and transatal extended gastrectomy, but results are awaited. So this is the algorithm. This is for Japanese guidelines recommendation published around 1 year back only. And this also you can see for T1 and node positive, all patients should be treated as D2 gastrectomy. For T1B or N0, at least D1 plus should be done if it is a diffuse type or some T1B is there. For T2 and T4, the standard recommendation is to do neoadjuvant chemotherapy followed by D2 gastrectomy. So to conclude, staging lab plus peritoneal level cytology is must before surgery and NSCT. D2 gastrectomy is the standard of care. Bursectomy is not needed. Open or lap or robotic gastrectomy all have similar oncological outcomes. For CA proximal stomach, total gastrectomy or proximal gastrectomy can be offered. Proximal gastrectomy in only early lesions or T1 tumors. Type 1 or 2 G junction, macrocystectomy might be better, especially if it is involvement of lower esophagus is more than 2 centimeters. For type 3 G junction, total gastrectomy is best option. Thank you.
Thank you, Dr. Shivendra, for your very brilliant presentations and authoritative presentation. So, questions to Dr. Shivendra. Can I exit your sharing? Shivendra?
Yeah.
Yes. Okay, then. So, any question from our students or from faculty? Any discussions or any queries?
Sir, Assalamu alaikum, sir. Is there any need for pyloroplasty or pyloric drainage in case of proximal gastrectomy or sir, gastric conduit?
Proximal gastrectomy, usually it is not it is controversial, but there is no added benefit. But many people do before doing transaction, put a sponge holder and dilate the pylorus, but the data is not there much.
Okay. Any more question? Okay, then. Shivendra, can I just take 10 minutes more?
Yeah, tell.
Yes. Just I want to discuss the two scenarios with you.
Yeah.
Just I'm showing you. Just talk to you. Can you see the screen, Maru?
Yeah.
Yes. Okay. Just I'm coming. So these are the two scenario on gastric problem with the patient, 32 years old female. In September 24, endoscopy highly suggestive of carcinoma of the stomach involving the body. Histopathology, no malignancy. And November 23rd, body showed a large ulcer or proliferative lesion. Comments carcinoma of the stomach, where it is a gastric lymphoma. Histopathology, no malignancy. And that has been done by a very expert hand. The report was like this. So what is the
problem? That is why in these group of patients, either you have to do a biopsy on biopsy.
Yes.
Or take a help of endoscopic ultrasound. They can take a full thickness two-cut biopsies. And that will help in clinching these diagnoses.
Okay, that is not available as endoscopic ultrasound. But problem is that we discussed with the endoscopist, and he took a one by one after one biopsy, very deep core biopsy, but the similar report. But the wall is thickened, and the endoscopic finding is this. This is a very important problem.
Other approach is in this type of tumors. Other approach, but again, you have to do either ESD for these tumors. That facility should be there. That with the second approach, do ISD, and that will get a bigger tissue, and one will be able to confirm it is malignant or not.
Okay. Anyhow, that should be ensured whether it's malignancy or not. That's an important issue. Okay. Any faculty, any comment? Okay, then. Second thing is multiple endoscopies done in this patient, in the one in the March, May, August, and November on this 4 occasion. On March 1, large gastric polyp was excised at the distal body, histopathology gastric adenomatous polyp with dysplastic columnar epithelium. On May, ulcer proliferative lesion of the distal body, histopathology ulcerated inflamed hyperplastic polyp. And on August, same report, gastric adenomatous polyp with the dysplastic columnar epithelium. And November, broad-based adenomatous polyp at the same site. And report is like this. You see the endoscopy, the lesion, and repeatedly it was excising or snaring through the endoscopes. And next one is May 2024. Same thing happened already in the narrowband imaging. And the August 24, same thing happened. It is recur and again snaring done. And finally, November this month, revealed a recurrent broad-based adenomatous polyp at the same site to the distal body of the stomach. So, what is your suggestions?
Again, the problem is if the patient is ready, I think we should explain that if it is same site is recurring and it is distal, I think other option remains doing a gastrectomy to take it.
Okay then. Any comment from our faculty? Any faculty?
Sir, is there any need for lymphadenectomy or only gastrectomy, sir?
Because it appears here, it is early, it is
Benign.
not malignancy proven. So even a D1 gastrectomy should be sufficient.
Okay, sir.
But the problem again will remain if it turns out to be malignancy in the final stage.
Yes, sir.
So what our approach, what we feel is that D2 lymph nodal resection doesn't increase much morbidity.
Yes.
And additional 45 minutes you will be able to do a lymph nodal clearance.
Yes, sir.
Personally, I will prefer to do a D2.
D2.
It to be safer and not have a surprise later on histology.
Yes.
Sure.
Previous case, is there any role of frozen section, intraoperative frozen section, and ensure is it malignancy? Then proceed for D2.
You can send a frozen section, but again the issue remains if you wait for 45 minutes for frozen section, by that time what we feel by that time almost whole T2 lymph node dissection should be complete while you are waiting.
Right. Okay then. And this is the last one. 67-year-old female, difficulty in swallowing on solid food and early satiety fever, and ultimately endoscopy SML with ulceration of the gastric fundus, as seen in the image. Biopsy is squamous cell carcinoma, and which was reviewed by another pathologist, and also a squamous cell carcinoma grade 3. And CT abdomen was done, mildly enhancing soft tissue mass. 8 into 6.7 into 6 centimeters is seen in the fundus of the stomach, extending to gastroesophageal junction. The mass appears to arise from the posterior wall, projecting within the lumen. An impression is the interluminal submucosal lesion in the stomach gist or gist. CT chest NAD. CA and marker level is normal. MDT decision was a multiple biopsy done again, and the histopathology reveals a squamous cell carcinoma. And immunohistochemistry also revealed a squamous cell carcinoma.
I think we have also seen recently, but West have not seen, lot of G junction tumors of squamous cell histology. So last, I think we have operated around 8 to 10 cases now till now. For these tumors, what we prefer is, because the squamous cell carcinoma is there, we prefer giving chemoradiation, just like a cross protocol, because squamous cell carcinoma respond very well to radiation. But you have to be careful while radiation planning so that the stomach is not irradiated much. So later on, you can do a proximal gastrectomy, or even if required, evaluus is required, then also evaluus gastrectomy, esophagectomy, you can do it. So usually they can plan with IMRT or IGRT so that the stomach is not irradiated. So that in case we need to do a esophagectomy and do a intrathoracic anastomosis, then the stomach is also healthy. And we use a neoadjuvant chemoradiation for these tumors.
Okay then, thank you very much.
Sir, even it's a G junction tumor, sir, it's CWAT type 3. Sir, on which protocol we will give, sir, chemoradiation?
This is cross protocol we have used.
Okay. Sir, but the tumor epicenter is within the stomach, sir. So
Remains squamous cell carcinoma, because no chemotherapy, we can go or either do a gastrectomy. But most time the problem remains for even a type 3, it will be close to the G junction And in case some margin positivity issue is there, better to give chemo radiation first and then later on operate.
Okay, sir.
Okay, then thank you. Any question from students? No. Now a comment from our faculty members. I think Professor Jamal is here. ABM Jamal. Okay. No. Masood Karim, will you make any comment? Or Shoaib? Yes.
Thank you, Professor Shivendra sir. Shivendra sir's lectures is always informative for us. In the last year, we get his lecture on distal gastric cancer, and today the confusions and all the latest aspect of treatments is exposed to our PGS academic students. We are very honored to have Professor Shivendra with us. Thank you. We will see you again. Thank you, sir.
Professor Ibrahim.
Sir, before Ibrahim, sir, I want to say something to Shirendra, sir.
Yes, sure. Sir,
Actually, the thing is that in our country, sir, most of the esophagectomy is done by the thoracic surgeons. So that's why today we were just listening, as we are not regularly doing this kind of surgeries, so we had less question. So, and few of these are G junction tumors and the upper Seward type 3, we, sir, try to do transhiatally basically. So with the lymph node dissection, quite inadequate sometimes. So now from your presentation today, I think everyone is very clear about the lymph node dissection 111 and 112. So by doing transhiatally, we can only able to achieve a negative margin, but lymphadenectomy is quite inadequate. So it is better to have a thoracoabdominal approach, or IVLO is better for us. So McKeown's, I don't know. McKeown's is still not practicing widely, sir, here.
For G junction, I think IVL should be.
Yes, sir.
And you have assisted so many esophagectomies here, so you should
Yes, sir.
do it.
Okay, sir. Thank you, sir. Thank you.
Thank you. Professor Ibrahim Siddiq. Yes.
Well, thank you, Dr. Shivendra Singh. Thank you very much for his elaborate discussion on this gastric cancer. I have discussed the details of the gastric cancer beginning from this initial presentation, then to tools for the evaluation, assessment, and hopefully this will allow our participants for critical thinking and formulating a very good strategy for treating gastric cancers. Today I have learned a lot from you. Thank you very much, Dr. Shivendra.
My pleasure.
Professor Margabhushan, sir.
Well, Professor Shivendra is always very systematic in presentation. I enjoyed that and learned many things about, at least about this esophageal cancers. I have tried 3 or 4 from the below. And one thoracoabdominal approach, but I will Lewis. It was successful, no doubt, but I don't know whether it was a resection, whether it was curable. It was not curative, it was just palliative. But we could achieve something that the patient was happy that they could swallow something. And McKinnon, yes, I have not seen someone doing here. Probably now these boys, they will start doing it. We have got patients there.
They should do.
But they come quite late, even now, because diagnosis is difficult, sometimes very tricky, and people do not want to go undergo operations here. When you say about chest, abdominal operations are not very, now everybody agrees quickly.